Hello, I'm Julie Miller from Focus on Dementia, and today I'm in conversation with Jacqui Pike, who's the Occupational Therapy Service Manager for Mental Health in Dumfries and Galloway, and is my key contact for the work that was undertaken in Nithsdale cluster to test connecting dementia practitioners to primary care. So I'm delighted that Jacqui's joining me to chat about what's taken place there over the past few years. So hi Jacqui, it's nice to see you. Thanks so much for meeting me.
Hi, Julie. Thank you for having me here.
So Jacqui, I think it's true to say that the past few years have been quite a roller coaster, not least with a pandemic during the programme and personnel changes and what have you. But there's certainly been a lot of learning came out of Nithsdale with the work. So I think for our listeners, could you tell me what the programme helped you test and achieve in Nithsdale?
Absolutely. It certainly has been a roller coaster, and there's certainly been an awful lot of changes that have happened. But I suppose the key things for ourselves in this, there were roundabout, we were able to test having an assistant practitioner sitting within primary care, and specifically looking at dementia, and their role was roundabout just offering advice and support to the primary care workers, not just GPs, but nurses as well. And they also were there to kind of give out information and leaflets and just really supporting people to come forward for diagnosis and supporting people to look for post-diagnostic support and what's available. We then, as part of that, recognised that, albeit we're looking at post-diagnostic support, we recognised that a lot of people actually weren't coming forward for diagnosis. So it allowed us to test out a model of having a dementia practitioner sitting within primary care, um, providing diagnosis and assessment and diagnosis, and linking remotely with a consultant psychiatrist, so the patients didn't actually see the psychiatrist unless they needed to, but the practitioner linked in with the psychiatrist. So that allowed the same person to provide a really robust assessment, and it was them, the same person, who provided the diagnosis and then instigated that post-diagnostic support follow-up, which started immediately from our healthcare support workers. We also did some training. It allowed us to do some training with psychology. So they did pre-diagnostic support training for all staff as well, so that they were able to start really preparing patients who were coming forward about, did they want to get a diagnosis and what that might mean for them. So really what we could say was we provide the diagnosis, but actually the post-diagnostic support started then with a healthcare support worker following up straight after.
Great.
Yeah. Yeah.
Yeah. And then you also had the clinics in the GP practices.
So the what it allowed was the GP. So if somebody was coming along to see their GP, either family members or the person themselves, that voiced any real concerns about memory or issues with cognition, the GP was able to book them straight into a clinic that was run by the dementia practitioner. So we had so many slots free for assessments and so many for diagnosis. So the GP could have the person sitting with them and allowed them to book people straight in. So it was that, very much that clinic model that was GP. And what the GPs really liked that, and they also liked the fact the dementia practitioner was around because they could have informal conversations and chats with them. I think 11 o'clock tended to be the time when they would be writing out prescriptions or maybe having a coffee break, that the dementia practitioner could go and have a conversation. It allowed them to just ask some questions round about supports for people, or was it appropriate for them to be referred in.
Yeah, yeah. And I mean, obviously the pandemic put paid to the actual clinic model in the practices for now, but is there if anybody wanted to replicate any of the work, Jacqui, is there any advice that you would give to others?
So I think what worked really well was having the assistant practitioner in the GP land, again just offering that bit of advice. But what we'd missed was that registered practitioner who could do the actual assessment. I suppose, yes, you're absolutely right. We had this COVID hit and we weren't allowed in the GP surgery, so we had to very quickly revert back to a different model. So referrals come straight into our secondary care hub, if you like, and they are assessed by nurses or OTs are able to do the assessment. But we've kept the part around about the remote diagnosis from the consultant psychiatrist. So we've been able to actually be able to see people quicker, and people can quickly get their diagnosis without having to rely on also being seen by a consultant psychiatrist. And people have reported they preferred that the assessment and the diagnosis is provided by the same person. It allows that consistency. but our consultant psychiatrist will step in if need be, if it's a bit more complex. Um, so that part worked as well, and we've kept that bit going. I suppose the big learning from us roundabout is around about sustainability and about having a service relying on just one practitioner. And when that practitioner went off on annual leave or went off sick, if there's no cover, then you're ending it with actually people waiting for longer because consultants were still booking people into a clinic, or you were relying on finding other staff to cover, which is not ideal either. So I suppose going forward, I would suggest that you make sure that you have the right staffing complement in there. You think about planning for people being sick, or maybe consider a hub model where GPs referring to a hub model, and then you've got practitioners who are linked who go and do the clinics within GP land, but the referrals come to a central point. So if you've got staff sickness, then you're able to manage that yourself, and you've probably a bit more governance over who gets referred. Because what we've also found is we've tightened up the whole physical health checks that need to be getting done. So any physical health causes are ruled out. So what you don't want is somebody being sent for a memory testing, or even that conversation, it might be dementia, when actually it's a physical health cause. So again, it's allowed us to tighten that up before even anybody's considered to come along to a clinic. So I think those would be the key learning points from ourselves.
Yeah, no, that's great. Really succinct points, Jacqui. Thanks. And I suppose what's happening now in your area, and what plans do you have in relation
Yeah,
to
so
all the work
yeah,
you've been
coming out of
doing?
coming out
Galloway?
of COVID now, Julie, that we're what we've agreed in Dumfries and Galloway is really that we're looking at a whole system change. So that's part we've got a mandated programme that we're, and it's sitting within mental health, that we're looking at a whole systems change of dementia, which is no easy feat. And we're starting to really look at some big room conversations round about, so from pre-diagnosis right through, what does that person's journey look like in Dumfries and Galloway, who's involved, where's the gaps in service, and where can we work jointly with our key stakeholders. So not everything sits in health or social care, but how do we pull in our wider stakeholders, and actually just communities supporting themselves as well. So that's where we're at. We really want to start linking back in with GP land to think, do we need to have that drop-in clinic again where people can get a bit of advice to ease some of those anxieties about, well, if I'm a bit worried about my memory, where do I go? Where can I go and get some support? And what would that pathway look like? We're linking quite closely with our new home team. So they're a multidisciplinary team that sits within primary care. So they have a single access point. We're looking at training and education with them because they're very often the first people going into people's homes. So they understand the process, um, and they know how and when to refer people, and then right the way through somebody's journey. So we're starting to map that out just now. So, and we're pulling in a lot of that learning and knowledge that we've got from this piece of work that we started.
Great. And that's all sounds fantastic, Jacqui. Thanks ever so much for talking to me. And if listeners want to learn more about this improvement programme, look out for other short videos in this series and resources on our Twitter feeds. So thanks again, Jacqui. Bye for now.
Thanks, Julie. Bye bye. Bye.